So now I'm going to discuss tube medications with you. So the first thing I would need to do outside the patient's room is I would need to make sure that I had verified the orders for medications and verified all of the medicines that I was giving. And as I'm going through and giving medications, I would always go through and do my 3 checks. And I always need to practice the 6 rights of medication administration. And you will have seen these in a prior video. So outside the room, I would have verified orders and done all of that kind of stuff. I would also do prior education with my patient regarding which medications I was given, the purpose for the medications, and if there were any pre-assessments that were necessary. For instance, if I was administering any medications that would have an effect on his blood pressure or heart rate, I would have need to have checked blood pressure and heart rate and any of those kind of things at this point. Some other pre-assessments might include assessing the bowels for bowel sounds, also distension, if the patient was vomiting. I also need to know if the patient's on suction or if they're getting tube feed, since I'm actually giving tube medications. Also, what type of tube the patient has, okay? So I'm now getting ready to enter the room. I'm going to knock and provide for privacy. I'm going to go ahead and foam as I enter. And as I come in, I'm always going to perform aid it, and I'm always going to do the 4 Ps. Hello, Mr. Smith. How are you doing today? My name's Heather. I'm going to be your nurse. Can you please tell me your name and date of birth? And as I'm doing this, I need to be checking his armband and verifying that what he says is true. I need to verify any allergies that he has, making sure that he doesn't have any allergies to latex or any equipment that I'm using. He does not have any. I'm going to go ahead and explain to him what I'm doing and give him a duration. Mr. Smith, I'm going to be giving you your morning medications, and they do include some blood pressure and heart rate medicines, and you know that I've already checked your blood pressure and heart rate. Since you've got the NG tube in, I've already listened to your bowel sounds and all of that stuff. Certainly I need to listen to bowel sounds with the suction off, as we discussed in the last video, because otherwise I would hear only the suction. I need to let him know that I'm going to turn his suction off while I'm giving him the medications, obviously, because if I don't, then the suction's just going to suck the medicines right back out. Also, once you give the medications, you need to leave the suction off for a minimum of 30 to 45 minutes so that it doesn't suck the medicines right back out and you allow for absorption. There are a couple of other considerations. For instance, if your patient would have tube feeding going, you might need to hold the tube feeding for a certain period of time before and after the medications, depending on what it is, because it could interfere with absorption. One such medication is Dilantin or phenytoin. He is not taking any of those medicines, and he's not on tube feeding. He's on suction, so I'm going to unestablish suction in just a minute, and then we'll move on with that. I need to ask him if he has any further questions or if he has any needs. He says that he's okay, so I'm going to move on with the procedure. So I'm going to come and grab my gloves here first, and I'm going to go ahead and put these on, again, because I'm going to be manipulating the tube, and I could be exposed to gastric secretions. I'm going to grab my waterproof pad, and I'm going to go ahead and place this on Mr. Smith so that I don't end up getting any gastric secretions on his bedding or any of that kind of stuff too. The very first thing I need to do is go ahead and turn off the suction. So anytime I come and use the tube, I need to make sure that I'm clamping it off without pulling on his nose first of all. I'm going to go ahead and pull the suction tubing here apart and go ahead and put the anti-reflux valve back into the tube. I can now unclamp, and that way I have unestablished the suction. I'm going to go ahead and move this back over here out of the way. Please make sure you've checked your tubing before you do this, because it could leak, and you probably want to go ahead and suck back up any of the secretions up into the canister as you're doing this. I'm going to go ahead and turn the suction off at this point because, as I said before, you need to leave the patient off of suction for a minimum of 30 to 45 minutes after you give medications, or it'll be suctioned back up in the tubing. At this point, I would recommend going ahead and taking off the gloves and go ahead and foaming again, because, you know, you've gotten some secretions and things on your gloves and everything, and then you're going to want to come back over and get a new pair of gloves. The next thing I need to do is go through, and anytime I come in and manipulate NG tube, feeding tubes, any of that kind of stuff, I need to always make sure the first thing that I do is confirm placement. So, the first thing I'm going to do is go through and I'm going to measure the tube. Now please remember that the chest x-ray again is always the most accurate way to confirm placement, but again, they're not going to do that every time that you're manipulating the tube. So I'm going to go ahead and unhook this from his gown first, and again move the pin and the stuff off to the side if it is in your way. Make sure you save it so you can use it again later. I'm going to go ahead and stretch the tube out, but without pulling on the patient's nose with the tube. Again, you would have documented the length of the tube from the patient's nair to the end, once you had placed it, or whoever placed it would have done that. I'm going to go ahead and straighten out the measurement and measure all the way down to the very end of the tube with it completely lengthened. And again, I'm confirming that this is 79.5 here with it lengthened out. I'm going to then place it back up above the level of the patient's stomach. And I'm going to come back over here, and now I'm going to come and I'm going to pull up 5 to 10 milliliters of air in my piston syringe. And I'm going to go ahead and clamp the tube. Take the anti-reflux valve out and attach the actual piston irrigation syringe. I'm going to put my stethoscope back in. I'm going to then listen over the patient's epigastric area while I inject the air and listen for the whoosh. I can now come and take my stethoscope back out. I can then aspirate or pull back until I get some gastric secretions. Again, I need to clamp the tube without pulling on the patient's nose, and I can put the anti-reflux valve back in, and again above the level of his stomach. I can come and put the secretions over here on the pH paper, and again I'm looking for the pH to be less than 5.5 according to your text. Most of your gastric secretions would probably be 0.4 less. So I have confirmed placement by length, I've confirmed by air if your agency policy requires that, and I have also done pH. I'm now going to come over here, and I would have whatever irrigant that I'm using, and I could then irrigate the tube at this point. I am in here to give medications to Mr. Smith, and so anytime that you put irrigant through an NG tube, you always need to make sure that you record that in your intake. Any of the medicines that you give are going to be intake. Anytime you aspirate anything, that, if you do not put it back in, would be considered output. But most of your gastric aspirate you're going to put back into your patient, and we will discuss that further when we discuss tube feeding in the next video. So I've now confirmed placement, and I'm going to come over here and we're going to discuss medications. Whenever you give tube medications, if they're going down the tube, obviously you need to make sure that you've confirmed the 6 rights, and you can't change the route that the medicine is ordered by. You have to have the doctor to change that. But you can crush the pills, because obviously I'm not going to put the whole pill down the tube like this, or it would occlude or it wouldn't fit through, as long as the pills are able to be crushed. You need to check your drug guide or check with your pharmacy or what reference you have to make sure that it's okay to crush the pills. You do not want to crush any that are sustained release or extended release or any of those types of things. If you can get them ordered as liquid, that is probably the easiest way to do it. But we're going to say that he has several pills ordered here, and of course we would perform the 6 rights of medication administration, to where we would verify the right patient, the right medication, the right dose, the right route, the right time, the right documentation, go through all of those things. You also need to check your medications for expiration and all of those things. So we would have gotten the individual pill, and we would come over here with the crusher, and you would put the pill in here and you would crush the medication, and then you would take it and you would put it into the individual container in which to give the medication. And I would put that in here. And then if I had a second one, I would need to clean in between the medications, crush the second medication, and use a different straw and put the medication down in the second cup. So we're going to say that I have 2 different medications in 2 different cups that have been crushed. I'm now going to come over and use whatever irrigant is ordered. Most of your hospital policies are going to use tap water, both for the irrigant and to mix the medications. But please make sure you check, because some agencies will require sterile water, and you don't want to make sure to give your patient too much free tap water. You could alter their fluid and electrolyte status. So always make sure that you check back on that. Anytime I have got the medications crushed, I then need to add whatever I'm supposed to mix them with, and add up to a 10 milliliter amount. Each medication must be mixed with 10 milliliters of whatever the solution is. I've got my medications prepared. I also need to make sure that I've got the irrigant or whatever I'm flushing with in the container, and I need to have enough of that as I'm going through. Now, as I said, anything you put through the NG tube and you're instilling into your patient is considered intake. So some folks like to have a piece of paper with an ink pen over here so that they can write down how much they're putting in every time. Because I'm going to give 10 milliliters with the medication, and then I need to flush with 10 milliliters between each medication. The best way to do this is to go ahead and take your piston irrigation syringe, and you need to take that out, and actually this is going to be attached for what we call free flow. This is the best and most appropriate way to give your medications. So I'm going to move this stuff around a little bit to make sure I have what I need closer. I'm going to move my table up here closer to my patient. I have already confirmed placement here of the tube, and you must always do that before you administer medications. The next thing I'm going to go ahead and do is I'm going to come over and I'm going to grab the tube without pulling on the patient's nose. Again, I've already confirmed placement. I must come down here and I need to clamp the tube. Now, one difference you'll note here is that I do not have the plunger in the syringe. Therefore, when I take the anti-reflux valve out and put the syringe in, I must continue clamping with my hand, because if I do not, I'm allowing air to enter the patient or secretions to potentially back out of the patient since the plunger is no longer in here. So I need to keep it clamped in my hand, and you'll notice it's like you have to have 4 hands to do this. I've got it clamped, and this is here. I also don't want to let this fling around. Obviously, I hit the patient, but things could, spill down in his lap. So what I'm going to do is come over here, and I need to irrigate the tube. So I would put whatever the prescribed irrigant is. I'm going to put about 10 milliliters here, and I would watch the level of the liquid. And then what I need to do when I'm ready for it to infuse, I'm going to unclamp. And gravity is what helps this infuse. So the higher you hold it, the quicker it's probably going to go. I now need to clamp the tubing back before the liquid runs out of the syringe. I have now pre-irrigated the tube. I'm now going to come over here, and my medication is mixed up with the 10 milliliters of solution. You can have your little straw over here for each medication if you want, because you don't want to mix them up. And you can kind of agitate it a little bit here to mix it up. Come and put the 10 milliliters of the medicine in here. Once I've got that medication in here, I can now unclamp and let the medication instill by gravity. Again, I want to come back down and reclamp it. Then I need to come back and I need to flush with 10 milliliters of the irrigant. Again, unclamp and let it instill. And I need to reclamp again before all that medication and liquid runs out. I now have my second medication. I would have a new straw that I could come and agitate it. I will come and I will instill the medication. I'll open up, let it go in by gravity, and before it runs out, I'm going to go ahead and reclamp it and hold it again. Now let's say all the medication didn't come out of this cup. So I need to come and flush first 10 milliliters. Let that infuse and come back and clamp again. Then I can put another 10 milliliters in here with the rest of that medication if I need to and re-agitate it and give again. All of it came out that time. I'm going to hold it up and unclamp, let it instill, reclamp it again. Then I'm going to come back and finally flush with whatever the prescribed amount of liquid is. At the end, depending on your hospital policy, you may flush with 10 milliliters or more. So I'm going to go ahead and flush with about 30 milliliters to make sure that I'm clearing the entire tube. I'm going to go ahead and hold it up. I'm going to clamp it off. I am now completed, because I only had 2 to give at this point, and I have flushed once I'm finished. So I'm going to go ahead and take this off. I'm going to put the anti-reflux valve back in, and I'm going to put it back above the level of the patient's stomach. I'm not going to reattach it to suction, because obviously all of it would be suctioned back up into the wall canister. So at this point, I need to make sure that he tolerated the medications and how he's doing. Anything that I pre-assessed, I would need to go back sure and reassess. I would also keep the emesis basin close by, because sometimes when your patient's on suction and then you put things down there and you turn the suction off for a little bit, they can get a little nauseated. I could have pre-medicated him for pain or nausea if he was having any of those things before I gave him the medications. At this point, I'm done giving him his medications. I'm going to go ahead and take off these gloves. I'm going to go ahead and foam again. And I need to go ahead and reconnect his tube to his gown. So I'm going to go ahead and get the equipment that I had. I'm going to go ahead and wrap this back around the tube. And as I'm doing this, I need to make sure, if I can get it back around here again. There we go. I need to make sure to have him turn his head to the side and make sure that it's not pulling on the tube. Of course, the needle never goes through the tube because it could puncture it and cause leakage. I'm going to attach it up here and make sure that the tube is sitting higher than his stomach level. Without pulling on him, I'm going to go ahead and get the waterproof drape off of him, and I would come back and dispose of it appropriately. If he didn't need the tissues or the emesis basin anymore, then I would go ahead and clean all that up. I need to go ahead and make sure that he's in a proper position. Again, I've just given him medications, and he's got an NG tube in, so he is predisposed for aspiration. So normally we would leave him up in at least a semi-Fowler's position. I could lay him back just a little, but again, not too far because he is predisposed for aspiration. I need to make sure he's not in any pain. I need to medicate him if he needs it. I need to make sure he doesn't need to get up and go to the bathroom. And if he did at this point, you need to be careful because you did just instill a great deal of liquid here, and you want to make sure he's not going to have any issues with it. And then also I need to make sure that he has things within proximity. His call bell is here. Once I clean the table, his table needs to be back over here for him. I've addressed the 4 Ps. I need to make sure for safety that his bed is low and locked and that there's no issues with it. See how he tolerated the procedure. And then, of course, if I did the pre-assessments, as I said, I'd want to come back in 30 minutes and do reassessment. So, for instance, if I gave him medications that would affect his blood pressure, heart rate, or any of those kind of things, I'd want to come back and reassess those and for his tolerance. Also, if he is ordered to be on suction, I would need to come back in 30 to 45 minutes, again, recheck placement, and then reestablish his suction as ordered. But I don't want to do it any earlier than that to make sure they don't suction out any of the medications. Before I leave the room, I need to thank Mr. Smith for allowing me to care for him today, and then make sure he doesn't need anything else before I leave, and then I'm now done with giving the tube medications. Thank you very much. So now I'm going to talk to you about actually discontinuing the NG tube. So as I'm outside the patient's room, I always need to verify the order that says that the NG tube should be discontinued, and I need to make sure I'm correlating that with the patient's presentation and assessments. So hopefully the patient has not been having any nausea or vomiting or any complaints of abdominal discomfort, hopefully at least for the last several hours, and hopefully they either have been on suction and not getting out as much, or they've been turned off suction and the tube is actually clamped. But if you go into the room and your patient is still complaining of nausea and they're throwing up and they're having a lot of abdominal pain and you're still seeing a lot of secretions in the suction canister, you might want to speak with the doctor before you discontinue the tube to make sure that the order is warranted. So always make sure that you are mindful of your patient's condition, but also checking the doctor's order and correlating and speaking with the doctor if it's questionable. So we've been outside the room, we verified the order, we would need to gather any equipment that we needed, and then before we enter the room, make sure that we're mindful of the procedure. So I'm going to enter the room, I'm going to knock, I'm going to provide for privacy, I'm going to go ahead and foam in. As I'm entering, I'm going to go ahead and perform AIDIT, and I'm going to acknowledge and introduce. Mr. Smith, how are you doing today? My name is Heather. I'm going to be your nurse. I'm also going to identify the patient. Can you please tell me your name and date of birth? And as he's telling me, I'm going to correlate with his armband. I'm going to go ahead and explain and give him a duration. The doctor has ordered that your NG tube can come out today, and it sounds like that you've been feeling better. And I'm going to make sure that, again, his picture is correlating with the assessments and things. I've listened to his bowel sounds with the suction turned off because, again, if the suction is on, all you'll hear is the suction. He has active bowel sounds. He's not complaining of any nausea. He has not been vomiting. He says he's feeling better. Whenever I did look at the suction, he has a lot less secretions or no secretions over here, so his clinical picture is consistent with the doctor's order for the actual discontinuing of the tube. So I'm going to go ahead and take this out, and it's probably only going to take me 5 to 10 minutes to get it done. It may well be a little bit uncomfortable because, of course, the tube has been in there for a little bit, and it will irritate your throat as it's coming up. I'm going to go ahead and give you some tissues here so that if you need to wipe your nose or anything as we're finished. I'm also going to put an emesis basin here because it could potentially make you get a little sick to your stomach. I'm also going to go ahead and put a waterproof pad here because I need to make sure that I don't get any of the secretions and things on him while I'm pulling this out. And then I can also use that to wrap the tube up when I'm finished. When I take the tube out, I need to make sure that I've got a red bag here, or based on your facility policy, because the tube will most likely need to go into this to be thrown away. I also need to make sure that I've got the equipment here to check placement because, as I've said to you before, anytime I do anything with the tube, I need to check placement before, even if I'm pulling the tube out, just to make sure that there aren't any issues. So I certainly need something to measure it with, some pH paper. I need my piston irrigation set. Again, if it's already been in the room, I need to make sure that it's within the expiration date, and this one is date, time, and initialed, and it's within it. I need whatever the order irrigant is, okay? And then I need to make sure that everything is where I need it and all that stuff. I'm going to go ahead and get me some clean gloves because this, again, is not a sterile procedure. I've already foamed in whenever I entered the room. I'm going to go ahead and come over here, and he actually has suction still going, so I need to disestablish the suction before I start. So the first thing I'm going to do is take the pin loose without pulling on his tube or irritating his nose. Go ahead and get this pin, and if it's coming out, we should be able to get rid of the pin, but please remember the pin can actually stick somebody, so you might want to get rid of it in the sharps box whenever you get finished. As I'm coming through and I need to disestablish the suction, remember I always must clamp the tube first. I'm going to disconnect the suction and go ahead and put the anti-reflux valve back in my tube and keep this above the level of the patient's stomach. I'm going to then come over here and pull the tubing over here. Make sure it has suctioned out any secretions and stuff up into the canister. I'm going to go ahead and turn off the suction. Now, you are going to need to get rid of the suction canister based on agency policy. Some of them have an additive that they put in there to solidify the contents. But also, please remember, anything that is in the suction canister is considered output and therefore needs to be addressed as same. Anything that you put into the tube is considered intake and, again, needs to be addressed as the same. So when I got ready to dispose of this, I would most likely need a red bag and dispose of it per agency policy. I'm not going to do that at this point. Instead, I'm going to come over and I'm going to take my gloves back off and I'm going to go ahead and foam again. Once I get all foamed and stuff, I'm going to go ahead and get a new pair of gloves. And I'm probably going to raise his bed to a working height for me. Remember, he must stay at least semi-Fowler's position here because he has an NG tube in and he is predisposed for aspiration because of that. I could roll him up to a higher level if needed. For now, I'm going to get the bed to my working height, as I said. And he can tolerate a higher position, so I probably am going to bring him up just a little bit. I can put the patient's bed rail down at this point if necessary, and I would probably prefer that, and I think he would too, so I can get there and move around a little bit better. The first thing I need to do again is establish placement. So the first thing I'm going to do is come over, and I like to measure first. So again, without pulling on the patient's tube, I'm going to go ahead and I'm going to measure from the entry at the patient's nair for the tube, and I'm going to lengthen the tube out here until the very end and measure to the end of the clear plastic. And again, it is to the 79.5 that I had pre-measured. I'm going to move this back up above the patient's level of the stomach. I've now measured. I'm going to come over here and with my piston irrigation syringe, I'm going to pull up the 5 to 10 milliliters of air based on facility policy if they're requiring this. I'm going to clamp the tube. I'm going to take out the anti-reflux valve. Of course, all of this without pulling on the patient's nose. Now that I've got the actual piston syringe in here, I can lay this down for a minute since the syringe is still in there and attached. Put on my stethoscope. Come back down to the patient's epigastric area. Again, inject the air, listening for the whoosh. Now that I've heard that, I'm going to come back up here and I can pull back or aspirate and get some gastric contents. I can then clamp the tubing and put the anti-reflux valve back in and above the patient's stomach. Come over here and put the actual aspirate on the pH paper. And I need to confirm, and your textbook says that your gastric pH should be 5.5 or less. Most of them are going to be around 0 to 4. Now, depending on your facility policy, they may have you clear this with normal saline or sterile water or tap water, or they may have you clear it with air. I prefer to clear the tube with air because that way, whenever you're pulling the tube out, there's no risk of leakage of the saline or whatever coming back out of the tube and getting into the patient's lungs. So what I'm going to do is come and I'm going to pull between 30 and 50 milliliters of air up in my piston irrigation syringe. I'm now going to come over here and again clamp the tube because I have already confirmed placement. I'm almost ready to pull the tube out. take the anti-reflux valve out and attach the syringe. Before I get started, I need to explain to Mr. Smith that this may be a little uncomfortable again, and I'm going to have him take a deep breath when I get ready to pull it out. First, I need to go ahead and loosen up the securement, and you may have something like an adhesive remover that will assist you in pulling it off so that you don't end up hurting his nose quite as much. Please tell him that, make sure if you're having any discomfort, let me know. You would have need to discuss this with him before you started if you needed to stop or any of that kind of thing. If he needed pre-medication, we would have already done that. At this point, I'm now ready to instill the air.